So welcome to this series called The Perioperative Coach. In this series we have top tips on all aspects of perioperative care from some of the world's experts working together to enhance surgical recovery. Don't forget to look on the show notes on topmedtalk.com for additional links to papers, etc. And of course, if you haven't done it already, subscribe to Top Med Talk. Top Med Talk.
This piece features Monty Mythen with Paul Wishmeyer, Professor of the Department of Anesthesiology, Duke University. Have a listen.
The vast majority of people who go into medicine, they are very, very caring people. Usually. I mean, that's kind of like...
I'd like to believe so.
Top of the list when you're trying to vet out medical students, nursing students, whatever it is you're looking for people who care, who have empathy, and you kind of get the impression that when we start in training, we've all got it.
I hope so. I've always wondered, is there a way to teach it? Is there a way to create patients of young medical students or doctors and actually have them care for each other for a day or for two? And there are empathy scales, of course, you can measure such things. And would it increase the empathy if you suddenly were the one laying in the bed having to stick an IV into your friend or put an NG tube down your friend's nose, and how you might perceive them, knowing you're going to see them tomorrow as a colleague, not just as a patient.
So do you think there's any, because some of the stories you've told us, like people coming into bathrooms when you're in hospital and when you've been in distress, do you think many of those people were burned out? That they've just they've forgotten, they've stopped noticing?
I do. You know, we are asked to do more and more with less and less time and less people. Work hours permeate the world's care paradigm where residents can't work the hours they worked before. They don't have the connection to the patient, perhaps because they're handing off to each other numerous times a day. We have less of them, and yet the patients we have more and more patients to care for as the world ages. And I do think so. So I think the lists of patients, say a pain service or perioperative service needs to see is exceedingly long, and you're expected to see so many people a day. And to do so, you have to keep moving. And so the inconvenience of a patient, like in my case, being in the bathroom naked trying to change an ostomy pouch, slows down the pain team looking at my epidural. And so they just decided a whole group of 10 of them would march right into the bathroom with me naked to look at my epidural as I bled, and really had tears in my eyes trying to deal with something I was dealing with, but they had a job to do, and I was one of those jobs.
Now, in reflecting on all of this, part of what we were talking about was, let's call it the curse of the electronic health record and emails and communication. Is I feel it, I see it myself. I definitely see it in the junior doctors and the nurses and other practitioners. They're slaves to getting that record completed and signed off. Absolute slaves to it. One of the things I didn't like when I worked in America 20-odd years ago was the pressure to keep my billing verifications up. You know, in other words, to demonstrate that I'd done stuff by recording the whole time. It seemed to take up a disproportionately large amount of my life, and I think maybe was starting to burn me out and therefore was making me grumpy and less caring. Are we in that world now?
I think we are. You know, as any American physician will attest, we have expectations every day that we have to be doing all the prerequisite charting on patients. You know, if you didn't put it in the electronic medical record, it didn't happen. Even if you may have spent an hour with a patient and their family talking about something that, honestly, you know, last week I was having end-of-life discussions with patients, and they were making big decisions as families. Much of it was just talking about the patient, who they were. I don't know that much of that is relevant to put into a chart, but it was an hour of my time, and so if I don't document something for that period of time, even if I'm not billing for it, I didn't do anything that day. And so it's interesting, the requirements by which we're judged.
Do you think they could do more of that with CCTV and just accept the fact that we're honest people? And if they really, really want to check, they could look at the footage. Because you do nutrition is a major part of your personal life, a major part of your working life. I do. But you're also a critical care practitioner. So you round on adult critical care on a regular basis?
I do. That's what I spent all of last week doing.
And that's right. It's called intensive care for a reason. We might have lost sight of that. But it's an intensively caring place. It needs to be.
Yep.
And do you think we might be becoming less caring as practitioners because of those requirements, the relentless requirement to document?
I think it makes it more difficult. And there's a certain anxiety that's always in the back of your mind. Did I get all my notes written today? Have I finished all of the writing and signing of the resident and procedure notes? Have I checked all the boxes? Have I ticked all the right billing codes? it's the number one, I would say, negative aspect of being, say, in this case, a critical care physician. I love every minute of what I do. Otherwise, the caring for the patient, the dealing with acute situations, the end-of-life discussions, bringing comfort at the end of life when people need it. But the fact that I'm so worried every day, did I get my notes done? And if I don't get them done by midnight, all of a sudden the notes will change and all the data I had from the template from yesterday will be gone. And so I won't even be able to write the note. And it's challenging.
At Duke, you've got quite a mature electronic health record system now, which overlaps with various different applications.
Yes.
Do the patients have anything where they can give you a star rating, a bit like your Uber driver or your Uber driver does to you? I haven't seen it yet. But
I think there's probably some way. I don't think it's simple probably to access, and I don't know that it happens very much. I've not heard of it happening. I'm guessing that in the outpatient setting, perhaps you might see that more. People have long-term relationships with patients.
When we revalidate here, we have to go through a period of time where we hand out questionnaires to people. It's quite difficult to take the bias and pressure out of it, but you get feedback about your communication skills and caring, etc. Wow. It definitely ups everyone's game.
That's brilliant. I bet it does. I bet it does.
But I'm now sort of tempted by the idea of the fact that from our various different interactions with people that we could get a sort of relentless star rating that goes up and down. Because if your empathy and caring is dropping, if your score was dropped from a 4.9 to a 3.3, you might notice it and adapt. It's going to change slowly, isn't it? If it does with those metrics, it's not going to suddenly drop over a week. But if it's trickling down and down and down, you might turn around and say, "Oh yeah, have I stopped caring enough? Maybe it'll come."
Yeah, that's brilliant. I think some sort of assessment and feedback. And I think that's a big thing we in medicine, even for each other, could do better. We had a brilliant group of nurses this week prone our first patient in our surgical trauma ICU, and they came together as a team to take a very challenging patient to prone, actually, for various physical and acute illness reasons, and performed magnificently as a team.
And that is for people listening who are not familiar with this. We usually have people lying on their back when they're on mechanical ventilators. This is the technique where you flip them onto their front, which it seems as though it's very good for the lung.
Yeah, there's a New England Journal paper showing it reduces mortality up to by much as half at long-term outcome points. And so it was time for this patient to have that, and I said, let's do this. And they said, we've never done this in the surgical ICU here at Duke. And, some of the other ICUs do it, but we don't. And the charge nurse had looked at everyone and said, we're going to do this. And the nurse at the bedside said, I'll get all the stuff together. I'll read the protocol. So we do it the Duke way. And because you don't want to not do that. And so everyone and 3 respiratory therapists showed up and 7 nurses and doctor and a physician assistant PA. And it happened flawlessly. The patient was incredibly stable. And she went from a PO2 of 40 on 80% to a PO2 of 80 on 40%. She came off her pressors the next morning. So
the patient received
brilliant success.
Great therapy.
Yes.
And I'm sure during that great care, because everyone was thinking about their pain and their anxiety.
Oh, they're scary.
But I'm reckoning I'm guessing the team cared a lot more about each other during that as well.
They did. It was a calm, pleasant, supportive interaction, one that I intend to send some kudos through the Duke systems of sending kudos to nurses and teams because they deserve it, and I think we don't do that enough.
Top Med Talk. Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.